Okay, picture this. Someone is in, well, just a state of absolute turmoil. I'm not talking about just having a bad day, but something much, much more intense.
Yeah, like the sources we've looked at, they describe it as being excited, agitated, or aggressive.
Exactly. And it can even go further, involving things like delusions and perceptual changes like hallucinations. It sounds like a really critical situation.
It really is. And when you look at the medical guidelines, like the Ghana Standard Treatment Guidelines we're focusing on today, there's a specific term, the acutely disturbed patient.
Right. It's a label, basically, for someone going through this extreme distress, maybe even a break from reality.
Precisely. And that's what we're trying to unpack in this deep dive. We're using these guidelines as a sort of map.
A map to understand what the state is, what kinds of things might be causing it, and crucially, how doctors and nurses approach it right at the start.
Yeah, those first moments are key.
So, whether you're just curious or maybe you have professional reasons to understand this better, we want to give a clearer picture of this really challenging medical situation.
And like you said, our main source here are these medical guidelines. They're meant to be practical, how to spot it, what to do first.
Okay, so let's dive in. According to these guidelines, what really defines someone as acutely disturbed? What are we actually looking at?
Well, you mentioned the core things, excited, agitated, or aggressive. But the guidelines, they add more detail. They talk about delusions.
Those are the really fixed, false beliefs, right?
Exactly. And perceptual changes like hallucinations, seeing or hearing things that aren't there. What's also really telling is the mention of disorientation, confusion, maybe altered consciousness.
And that's especially if the cause is organic, meaning like physical.
Right. Something biological or physical going on, not purely psychiatric at its root. It paints quite a picture.
It really does. I mean, the guidelines even say these patients are usually brought in restrained by more than one person or by the police.
That detail really hits home, doesn't it? The sheer intensity, the potential danger for everyone involved.
Absolutely. And it's stressed how urgent this is.
Oh, definitely. The guidelines are explicit. The condition must be regarded as an emergency, since a few cases are potentially fatal.
Wow, potentially fatal. So time is absolutely critical.
No question. It needs immediate attention, immediate action.
Okay, so we get the severity, the urgency, but what actually causes someone to get into this state? It feels like it could be, well, almost anything.
You've hit on a really key point there. The list of potential causes in the guidelines is remarkably broad. It shows just how complex diagnoses can be.
So how do they break it down?
They use categories, like HELPs. First up is acute functional psychiatric disorders. This is probably what many people think of first.
Like what specifically?
Things like mania or hypomania, those periods of really high energy and mood, schizophrenia, and similar psychotic states. Other psychotic disorders, agitated depression.
Agitated depression. So depression, but with intense restlessness.
Yeah, exactly. And just a general category for acute psychosis. So these are primarily rooted in, let's say, mental health conditions.
Got it. That makes sense. What's next?
Then there's acute organic psychiatric disorders. And this is where you really see the mind-body connection.
Organic, so physical causes again.
Right. This includes toxic psychosis. That's when substances trigger it. They list things like amphetamines, cocaine, marijuana, heroin.
A lot of common substances of abuse.
Definitely. Also, bad reactions to alcohol intoxication, and the really serious one, acute alcoholic withdrawal syndrome.
Delirium tremens or DTs, yeah, that's known to be incredibly dangerous.
Life-threatening, potentially. And still under organic, you've got infections.
Infections can cause this, like what?
Serious ones. Typhoid, malaria, meningitis, HIV, encephalitis, even hepatitis. It's amazing how an infection can impact brain function so dramatically.
That's quite sobering. It really broadens the perspective beyond just mental health or substance use.
It absolutely does. And there's more.
Okay, what else is on the list?
The guidelines mention acute metabolic disorders.
Metabolic, like body chemistry.
Exactly. Things like hypoglycemia, really low blood sugar, thyroid disease, which can wreak havoc on mood and energy, and porphyria, a group of rarer genetic disorders.
So even your blood sugar or hormones being off could potentially lead to this kind of acute state.
Potentially, yes. It shows how interconnected everything is.
It really does. Any other categories?
There's a final catch-all others category. It specifically lists head trauma and subdural hematoma.
Bleeding on the brain, so physical injury too.
Right, a direct injury impacting the brain. So you see the range: psychiatric conditions, substances, infections, metabolic problems, physical trauma. It means you have to cast a really wide net when trying to figure out the the why.
It certainly drives home that this isn't a simple single-cause issue. It's complex.
Incredibly complex, which leads us to the next point. How do you even begin to assess someone in this state? What signs and symptoms are they looking for?
Yeah, how do you start piecing it together? The guidelines make a useful distinction here, right, between symptoms and signs.
They do. Symptoms are more what the patient reports or what you might observe them doing, their behavior. Signs are more the objective findings from a clinical assessment.
Okay, so thinking about symptoms first, what might the person be experiencing or showing?
Well, the list includes things like severe sleeplessness, being really restless, maybe pacing, agitated, or sometimes even combative.
Physically aggressive.
It can happen. Their talking might be excessive, really loud, or the complete opposite, very little speech, quiet, maybe even mute.
Extremes, then.
Often, yes. You might see disinhibited behavior or speech or doing socially unusual things. They might talk about hearing or seeing imaginary things, hallucination.
Emotional state.
Could be intense fear, strong suspicion of others, maybe inappropriate guilt, or expressing really bizarre beliefs. And sadly, destructiveness is also mentioned.
Towards themselves or property.
Potentially either, yes. It's clearly a major disruption of their normal self.
Definitely sounds like it. Now, what about the signs? What would a doctor or nurse specifically look for during an examination?
Okay, so signs could include their mood, maybe really elated, euphoric, or the opposite, irritable, angry, deeply depressed. Physical signs like aggression, agitation, restlessness are key.
Things you can directly observe.
Right. A lack of insight is common. They might not realize their thoughts or actions are unusual. Speech can be a big clue. Very fast, hard to interrupt, that's pressured speech.
Yeah.
Or really slowed down, retarded speech.
Motor activity, too.
Yeah, either hyperactive, constantly moving, or significantly reduced movement, almost slowed down physically. Disinhibition, socially or sexually, might be observed. And delusions are a major sign beliefs about being grandiose, extremely guilty, or paranoid.
And hallucinations.
Yes. Auditory hearing things is common in some conditions, but the guidelines make a really interesting point about visual hallucinations.
Seeing things, what about them?
They specifically note that seeing things is more common when the cause is toxic, like drugs or infectious, or related to withdrawal.
So that specific symptom might point towards an organic cause. That's a useful clinical pearl.
It really is. Other signs mentioned are fever, which obviously suggests infection, drowsiness or altered consciousness, especially noted with alcohol withdrawal, disorientation, confusion, also linked frequently to withdrawal.
And physical signs, too.
Yes, things like sweating, tremors, again, often seen in alcohol withdrawal. So, putting all these symptoms and signs together starts to build a picture, potentially pointing towards likely causes.
It seems like careful observation is absolutely vital, even while things are chaotic.
Crucial. It guides the next steps, including any investigations. Which brings us to that. What tests, if any, do the guidelines suggest right away?
It's interesting, actually. They say that usually there aren't routine, immediate investigations for everyone. It's more targeted.
Targeted based on suspicion.
Exactly. So if substance use seems likely, they recommend a urine screen looking for things like amphetamines, cocaine, heroin, cannabis.
Makes sense. Rule that in or out quickly.
Right. And if the person has a fever and infection is suspected, especially malaria in relevant areas, they suggest a full blood count, FBC, and a rapid malaria test.
Good practical advice for specific contexts.
Definitely. They also stress checking random blood sugar because hypoglycemia, low blood sugar, is a possible cause we mentioned.
Another quick check that could reveal a metabolic issue.
And if a serious infection seems very likely, maybe a blood culture to try and identify the specific bacteria or organism, so it's not a scattergun approach.
No, it's focused on ruling out or confirming common, serious, or easily treatable underlying causes based on the immediate clinical picture. Okay, let's shift to the immediate actions of the treatment. What are the goals?
The guidelines state two main objectives right up front. First, rapid tranquilization.
Meaning calming the person down quickly.
Yes, reducing the agitation safely with medication, but importantly, not necessarily aiming to knock them out completely. Just calm things down.
Okay, makes sense. And the second objective?
Identify and then treat the underlying cause. So calm the storm, then figure out what's causing it and address that.
Right. Dual focus. So how do they suggest achieving that initial calming, that tranquilization? What about non-drug approaches first?
They mention using physical restraint, but only when absolutely necessary to prevent harm. And they stress doing it safely without causing injury.
That's a critical point. safety first, even with restraint.
Absolutely. They also advise talking to the patient calmly, firmly, reassuringly, and an interesting tip: avoid long silences, especially if paranoia might be an issue.
Keep the communication channel open, sort of.
Seems like it, and very practically, remove anything that could be used as a weapon. Secure the environment.
So, creating safety, trying verbal de-escalation, but often medication is needed, right? What are the pharmacological options mentioned?
Yes, medication is often essential. The guidelines list several options with specific doses and routes. Lorazepam is one, it's a benzodiazepine.
Like Valium or Xanax, that class of drug, calming effect.
Exactly. It's listed for IV or IM use in adults, usually 2 to 4 milligrams, repeatable once after 10 minutes if needed. There are also specific doses for kids based on age. The evidence level is noted as C.
Okay. Benzodiazepines work pretty fast. What else?
Haloperidol, which is an older antipsychotic medication. It can be given IM, starting with 2 to 5 milligrams for adults, repeatable every 4 to 8 hours, up to a maximum daily dose. Again, doses for children are given too.
Any cautions with haloperidol?
Yes, important ones. IM use isn't generally recommended for kids under 5, and oral use isn't recommended for under 3s, and they emphasize switching to oral meds as soon as the patient can manage it.
Good points. Any other antipsychotics?
Chlorpromazine is another older one listed. It can be given IM for severe agitation in adults with repeat doses possible. Doses for children too, but there's a huge warning.
Oh, that.
Never give chlorpromazine intravenously. In capital letters, exclamation mark. It can cause severe hypertension, a dangerous drop in blood pressure.
Wow. Okay, that is crucial. Route of administration matters immensely. Are newer antipsychotics mentioned? The atypicals?
Yes, olanzapine is listed for IM use in adults. They give initial dose guidance, repeat intervals, and a maximum daily amount. But it specifically says olanzapine is not recommended for children.
Interesting. So different options depending on age, perhaps. What about other sedating meds?
Chloral hydrate is mentioned. It's a sedative given orally or rectally for adults and kids. Dosing for little ones is weight-based, even down to neonates. Maximum dose is 1 gram.
And diazepam, another benzodiazepine like lorazepam.
Yes, diazepam is listed too. For 5e use in adults, it needs to be given slowly, over 2 under 3 minutes. For kids, 5e is weight-based, also slow administration with a possible repeat dose, but there's a caution.
What's the caution with diazepam?
They note caution with IV diazepam if an organic cause for the disturbance is suspected.
Okay, so maybe less ideal if you think it's an infection or metabolic issue causing it?
That seems to be the implication. Diazepam is also listed for restal use in children with age and weight-based doses, including for neonates, repeatable once after 10 minutes.
Rectal route can be very useful, especially in kids.
And they even add a practical note. If the rectal tube formulation isn't available, you can actually use the injectable liquid, remove the needle carefully, and administer that rectally.
That is really practical advice for an emergency setting. Good to know.
Definitely. So, a range of medication options, each with specifics to consider.
Absolutely. Given all this complexity, the potential causes, the careful treatment choices, what's the final recommendation in terms of ongoing care?
It's very direct and unambiguous. Under the referral criteria section, it just says, refer all acutely disturbed patients to a specialist. Full stop.
Right. So the initial management, the tranquilization, the basic checks, that's just step 1. Everyone needs expert follow-up.
Exactly. It highlights that this is serious enough to always warrant specialist assessment and ongoing management.
That makes complete sense. So if we were to quickly recap our deep dive today, we started by defining this state, the acutely disturbed patient, marked by agitation, aggression, maybe delusions, hallucinations, confusion.
Yep. Then we looked at the huge range of possible causes, psychiatric conditions, yes, but also substance use, withdrawal, serious infections, metabolic problems, even physical head injuries.
A really broad spectrum. We discussed the key symptoms and signs clinicians look for, noting how some signs, like visual hallucinations or fever, might point towards certain underlying causes.
We touched on those initial targeted investigations, urine screens, blood sugar checks, maybe malaria tests or blood counts if needed. Not a huge battery of tests right away, but specific ones.
Then the treatment goals. Calm the patient rapidly and safely, rapid tranquilization, and start figuring out and treating the underlying cause.
We covered the non-drug approaches, safe restraint if needed, communication, securing the area, and then the various medication options. Lorazepam, haloperidol, chlorpromazine.
Olanzapine, chloral hydrate, diazepam. Remembering key things like not giving chlorpromazine the feed, and the specific routes and age considerations for each.
And crucially, that final point, all these patients need referral to a specialist. The initial ER or clinic management is just the beginning.
Absolutely. It really hammers home the complexity and seriousness. Reflecting on that wide range of causes, psychiatric, organic, metabolic, trauma, it really makes you think, doesn't it?
How so?
Well, just how deeply interconnected our physical health and mental well-being are.
Yes.
You can't easily separate them, especially in these acute situations.
Right.
An infection can present like a psychosis. A metabolic issue can cause extreme agitation.
That's a really powerful point. It challenges neat little boxes we sometimes put conditions into.
Exactly. And it highlights why maybe a team approach, a multidiscipline view involving different specialists, might be so vital for truly understanding and treating these complex presentations effectively. It's about seeing the whole person, right? Not just one isolated problem, something to think about.